So today I'm joined by Dr. David Feifel. David, how are you?
I'm very good, Claire. It's good to see you.
It's good to see you, and you are our first guest.
Well, I'm really honored.
You should be honored.
Really
That's
honored.
a big thing.
I hope they don't cancel the podcast after seeing me.
We'll see how it goes.
Okay.
We'll judge that
Thank
at
you.
the end. Okay.
A lot of pressure.
Oh, no pressure, no pressure. So, Dr. David, for people that don't know you, you run the Kadima Neuropsychiatry Institute in La Jolla.
That's correct.
So we're going to get onto that a bit later. But first of all, why did you get into this line of work?
Oh, wow. I've always been fascinated by the brain. And actually, early on, I was fascinated by the whole idea of consciousness. And when I thought about what I wanted to do with my life, I realized that the brain is sort of really everything we are and everything we perceive, and even things that I might study, in terms of more concrete things like physics, ultimately are a production of the brain, how we view the world and how we view the laws of the world, and so I became very interested in that. And originally, I didn't know how to go about that, whether I just would be a brain scientist, a neuroscientist, or I would be a neurologist. And so I ended up deciding that I wanted to become a physician and a neuroscientist. And and I was initially just mostly interested in the sort of the academics of it, the research. And I thought that was going to be my career, but along the way, I've kind of found it incredibly gratifying to treat people, for the most part. And then I had this dilemma where I was interested in expanding our understanding of the brain, but I was also interested in applying it to help people. And I just sort of carved out a pathway in terms of doing both. So.
Okay.
That's sort of how I got to do what I'm doing.
So talk to me about depression. Like, what is depression?
Well, depression. We're so used to the term depression in a colloquial fashion, where we would just talk about feeling down or even sad. People say they're depressed, because because their sports team lost and so forth. But when we talk about depression in medicine, we're talking about a clinical disorder of the brain, for the most part. And we understand that depression is a malfunction of the parts of the brain that allow us to maintain engagement in life and motivation, and look forward to things and so forth. So when things go askew and people have depression, they basically find that they cannot feel any pleasure. Nothing gives them pleasure. Nothing they can even imagine in the future gives them pleasure. And all the things that you and I and most normal people who aren't experiencing depression enjoy: food and social engagement, sex. All these things become uninteresting to people. So you imagine where you feel nothing. Nothing you can even think of brings you joy. And what happens when that occurs is that it makes everything so much more difficult, because I'll tell you something, 95% of what we do in life, at least, is not immediately inherently pleasurable. But
so, like what? Give me an example.
Well, I'll give you an example. Let's say you've got a job. You really don't enjoy your job. Your boss is a jerk, but you need the job because it pays the bills. So it's Tuesday, and you're going into work, and there's no, there's going to be no, nothing enjoyable. You're going to be barked at by your boss, and you're really not going to get any. You're not doing anything that you feel is meaningful. So our brains have an interesting trick. our brains are able, well, let me back up. You know, in our brains, all animals have an area which is the pleasure center.
Okay.
We feel, anything we feel pleasurable is because that area is active and firing.
Huh.
And that is across the board, whether it's listening to music you love, whether it's just learning something because you know that's what you enjoy, whether it's giving charity because that gives you a sense of satisfaction. All that, the common denominator is that pleasure centers are active. Now, with the human brain is able to tap into its ability to project into the future. And what it does is it takes a little bit of an advance payment from something in the future that we know is going to be pleasurable,
Okay.
To allow us to sustain our motivation for things that aren't currently pleasurable. So that person going into work on Tuesday, not looking forward to going to work, is able to do that because somewhere in the back of the brain they're thinking 3 more days and I'm going on vacation with my friends.
Yep.
And we're going to be going fishing, we're going to have beer, it's going to be great. So they may not be consciously thinking of it, but in the back of their mind they're aware that that's out there and that's future pleasure.
Okay.
And it allows them to sustain the effort to do what's not currently pleasurable. Now, imagine that gets shut down and you have depression. And there's nothing that you can think of in the future that would be pleasurable because you can't even imagine what feeling pleasure is like anymore. And imagine trying to do anything under those circumstances. It would be enormously hard. And I have patients who tell me that brushing their teeth is like climbing Mount Everest.
Wow.
Or taking a shower, you know, they have to marshal all their energy. Now, there are some people who are able to, on the outside, you know, go to work, get through a day's work, and even put on a face that allows them to, you know, nobody to know that they're depressed. But they will come home and they'll tell me, and they're depleted, and they'll get in bed, and you know, they're just basically doing it because there's enough enough energy not to lose their house or the money that pays for their children just to do this, but that's all they can do, and there's no joy in life. They're just taking care of business. You know, that's all it is.
Okay, so tell me about some of the people that come to you. I mean, like, what state are they in mentally?
Well, if you saw the people walking through my door, a lot of them you would not know just at first impression have depression.
Okay.
But they'll very quickly tell me, you know, a scenario much like I described, where, you know, they haven't felt any pleasure for years, sometimes decades, and they may be employed. Many of them aren't even able to work anymore. They've lost their job because they just couldn't sustain that you know, that output of energy and the concentration. And if they do, it's probably all that they do. And many of them will just break down in tears as we go through, you know, the lost years of their lives, because most of them have, by the time they've got to me, they've been experiencing depression for years, because my practice is focused on people who have tried other treatments unsuccessfully.
Okay, so let's now talk about Kadima. And talk to me through some of the treatments that you offer there, because as you've just said, the people that are coming to you, this is the end of the line for them in a lot of cases. They've tried many other things.
Correct.
Talk to me about the treatment that you offer at Kadima.
So Kadima was developed really with the concept of being a place that was going to offer people treatments that are not conventional. They're not the first line treatments, and they're treatments that are sort of a level up from the kinds of treatments you might get from your family doctor, or even from sort of a community psychiatrist if you started to see somebody for depression. Right now, we have two major treatments, and I will back up a little bit because it's important to know why these treatments are important. Well, the reason I really became very interested in new kinds of treatments was when during my time at UCSD, where I was there for 20 years as a professor, I became very frustrated because our mainstay treatments are talk therapy and antidepressant medications. And though we have a large number of antidepressant medications, they are very, very much a kind of a rehashing of the same sort of mechanisms or chemistry in the brain. Unfortunately, while they work for some people, there's a lot of people who just do not get any relief from either the talk therapy or the antidepressants, which means that a lot of people are quite desperate. They've tried a number of antidepressants. And I was getting patients referred to me from other doctors as sort of the expert in these kinds of treatments, and I didn't have a lot to offer because they'd already been on a dozen of these antidepressants in all kinds of combinations. And I thought, we have to develop something better than this. We have to have more options than just these treatments, which again, for some people work perfectly well, but for too many people just don't cut it. And so I became really focused on trying to identify emerging treatments. And fortunately, about between 10 and 15 years ago, there were two lines of new treatments that were being developed that I saw had a lot of potential. And today at Kadima, those two treatments are our mainstays, and we're of course always keeping an eye out for additional options. Okay,
so talk to me about the two main treatments you offer. What are they?
One of the treatments is called transcranial magnetic stimulation, and the other one is called ketamine.
TMS?
TMS for short.
Yeah. Okay.
Yeah.
Okay, so tell me about that first of all. What does that do?
So TMS, which by the way was approved by the FDA first in 2008 for depression, and more recently it's been approved for obsessive compulsive disorder, and we anticipate there'll be more and more conditions, not only psychiatric but neurological conditions like Alzheimer's and stroke and so forth being approved. So to understand what TMS does, we have to take a step back and understand what the brain does and what it's composed of. The brain is a somewhat mysterious, extremely complex biological computer. It's got 85 billion brain cells in it, which in essence are these biological wires. They fire. There's electrochemical activity occurring in our brains all the time in these 85 billion cells that run in various circuits, and different circuits are responsible for different things. So as you are listening to me now, you're able to understand what I'm saying because there's a part of the brain.
So just for people that are listening to us, what have you got in your hand, David?
I've got, this is my spare brain, which I carry around.
With one of
and,
those.
and sometimes it's not even enough. This is a model of the brain, and the outer layer is the cortex, which is sort of the most recently evolved area, and for which humans have sort of the most sophisticated version of. And we know we were able to attribute a lot of different functions to different areas of the brain. So I had mentioned that you're listening to me, and initially these meaningless sounds are coming through your ear, being turned into electrical impulses through the nerves in your ear. that send those impulses to an area around here at the back, sort of this.
So what kind of size is this? You're circling your finger. How big a size?
This brain is a little bit smaller than scale.
Okay.
So in an actual brain, it's probably the size of a silver dollar.
Okay.
And that is sort of the auditory area. It's an area called Herschel's area, and it takes that meaningless sound and it converts it to meaningful concepts based on your knowledge of language and all your experiences. So it taps into the vast knowledge of the rest of your brain, and those sounds make sense to you, and you understand. And you're able to, in a way, read my mind because my thinking and your thinking become synced. You understand what I'm trying to express.
Okay.
When you're looking and seeing me, the area at the very back of the brain, called the occipital cortex, that's the visual area. So that is active. So you see the brain is this remarkable organ with many small wires that communicate with each other, and the firing pattern at any given time is what we experience. And that also includes our emotional state. There are areas that are responsible for how we feel. There are areas that are responsible for joy, for fear, for anxiety. And we know that in different conditions like depression or schizophrenia, there are parts of this complex organ that are malfunctioning. There are circuits that are too active or underactive. And the idea behind TMS is, rather than try to normalize those areas in a very indirect way by taking a medication in your mouth and having it go through your digestive tract and getting absorbed into your blood, where it can produce side effects throughout your body, and then crossing over into your brain, where it can affect all the areas where that chemical has a role. Just to normalize or to regulate some malfiring in one area. The idea behind TMS is we can do this much more elegantly and selectively through technology. And TMS is essentially a device that focuses a pulsating magnet at an area that's not functioning well, and acts like a personal trainer for that area, and will stimulate it. Because we know from physics that a pulsating magnetic field will cause these brain cells to fire. And so it will non-invasively stimulate that area. And over time, that area, just like somebody who has an injury and needs physical rehabilitation, over time that area will start to function more normally on its own.
Okay, how do you actually do that though? Talk us through the process.
So the process is, for depression, we know that there's an area on the left side towards the front of the brain called the left prefrontal cortex. So when patients come in and we deem that they're appropriate for this, what we'll do is we will sit them in a chair, and we have a cap that has a coordinate system on it, so it maps out their skull.
And if people actually want to see this, if they go to your website,
right,
KadimaNU.com, is that?
It's Kadima, Kadima, N as in Nancy, P as in Paul, for neuropsychiatry.com.
Okay,
KadimaNP.com.
So if they go there, there's actually like video footage of this, so they can see like how this treatment's administered.
Exactly.
Yep. Okay.
And so what we do is on the first day, we map out where the depression area is, and then it's a very straightforward process. They come in every day. It's not a fast process, but it's sort of like physical rehab, or if you were out of shape and overweight and you got a personal trainer to kind of change that would take time. You couldn't go to the gym one day and expect
to run a marathon the next.
Exactly.
Yeah. Okay.
So they come in every day, and we stimulate that area of the brain. It takes about 30 minutes a day. It's quite benign because there's nothing invasive. There's a helmet that that sits on top of their head, and the beam is aimed at the particular area we're trying to strengthen. And they come in every day. They don't feel much at all. Maybe a little bit of a light tapping on their skull, because we actually don't. An interesting fact is we don't feel our brains. Our brains cannot feel sensation from themselves. They receive input from everywhere in the body. So when we feel any sensation, that's impulse coming from the nerves in that area coming to the brain and being translated into a painful or pleasurable sensation in the brain. But a neurosurgeon can cut into a person's brain while they're awake, and they would feel nothing. Because
really?
Absolutely.
Oh my goodness.
You can go on. There's plenty of YouTubes of that if you're so inclined.
Wow. Make sure you're not watching that on a full stomach.
No. So it's an interesting fact that the brain can't feel itself. It feels the rest of the body. So whatever patients feel, they might feel the sensation of the magnetic pulses that passes through their skin and their scalp. It's a light tapping. But over time, we know what happens is that those nerve cells in that area, actually, they go through a change, and they start to sprout more branches. A brain cell is sort of like a trunk with branches, and each of the branches connect with other brain cells, so they communicate with each other. They actually sprout more branches, and they make more connections with the nerve cells around, so that when one is firing, it kind of sets off a reverberatory loop, so it becomes more active. And after about several weeks of this, and typically it's 4 to 6 weeks, patients start to actually feel better. They'll start to report that they're actually looking forward to doing things. They'll say that oftentimes they'll say that just walking outside, things look different. The grass is greener, the sky is bluer. There's literally a change in the vividness of what they see. Family members will report, that they'll do something. Suddenly, they'll want to come along when the family goes out to dinner or something, whereas they almost, invariably would pass, and we start to see these changes, and we know we're on the right track. It's not a fast treatment, but it's very durable once it works.
Okay, so a patient would undergo this for several weeks. So this is the TMS. Talk to me about ketamine.
Correct.
Where does ketamine come in? And can I just ask you before you tell me about this, ketamine, I thought, okay, I don't want to show my age here, but maybe in the early 2000s, and I was back in rainy old Yorkshire, going out clubbing, ketamine was a recreational drug. People around me used to take ketamine, and isn't it a horse tranquilizer?
It is a recreational drug. It is a horse tranquilizer.
Yeah. So how has it come from that to being used in a medical setting?
Great. It's a great story of medical discovery. Well, originally, before it was a recreational drug, before it was used in horses or in veterinary medicine at all, it was developed as an anesthetic drug. It was first synthesized in the 60s, so it's been around for a very long time. And still to this day, its main use, by far, is an anesthetic. It's still one of the most popular anesthetics.
So it's used in the medical profession, but not in a psychiatry?
Not until recently.
Until recently.
Right.
So, and just to kind of add, the FDA has approved
a version of it.
A version of it, which we'll come on to later. But
tell
me, let's narrow it back down to ketamine and how you use it in your clinic.
Okay, well, this is a really, I think this is a very exciting story, because it really describes an emerging revolution in psychiatry that I'm very excited and honored to be experiencing and being part of. So it was first developed as an anesthetic, and it is remarkable even as an anesthetic because one of its properties is it is uniquely safe as an anesthetic. It doesn't suppress respirations, which has made it very useful throughout the world, in third world countries where they don't have access to expensive monitoring equipment, or they don't have enough anesthesiologists. surgeons can use it, and doctors can use it for simple procedures, and not have to worry that that a person will stop breathing or be concerned that they need to intubate them or put an airway down their esophagus, their trachea, so to protect that. So that's very unique.
So it's already been established as a pretty safe.
Absolutely,
anesthetic.
right.
Okay.
And in fact, its main use as an anesthetic is probably in children, because it's so safe, and because physicians often don't want to take children into an OR suite and intubate them with a tube. They can give them ketamine. And they can do shoulder relocations, or UCSD. They used to do dressing changes, which can be very painful just by giving people ketamine.
Okay.
But what's interesting is that ketamine was about 13 or 14 years ago was discovered, quite surprisingly, to have, at doses that are lower than the doses that put people out, to have a really remarkable effect on people's mental state. And it was discovered in a very small study that was done at Yale, that took patients who had treatment-resistant depression, meaning they'd failed other things, and they gave them low doses of ketamine as in an intravenous infusion, and to I think everyone's surprise, a very high percentage of those difficult depression cases had a very dramatic improvement. And that's amazing enough, but what was really remarkable was many of those patients improved within 24 hours, and sometimes even less, which is, in our field of psychiatry, is really unheard of. We don't really have treatments that we know will start to work in that period of time. It's usually waiting weeks, as it is with the TMS. Okay. So that was a pretty remarkable finding. In fact, so much so that a lot of people, myself included, were a little skeptical when the first small study was published. But then a few years later, there was a larger study out of the National Institute of Health that replicated that with a larger group of people and got as good, if not better, results. And I think when I read that, it was 2006 or 2007.
So in 2008, you were actually the first person to use ketamine for
clinical use.
Yes, right, absolutely. But what was the reaction from the wider medical community?
It was very controversial, and it took me. I was at the time a professor in the School of Medicine at UCSD.
What did your colleagues think to your
It took me about 9 months or longer just to get the committees to even agree to allow me to do this. And we were able to justify it because there are so many people, Claire, in the world who have treatment-resistant depression, and there are people like I can think of a patient I had who had been a high school teacher, been one of the most popular high school teachers. His kids had loved his class, but for the last 5 years, he had not worked and had barely gotten out of bed. And he told me of all the awards he won as a teacher, his greatest achievement and what he's most proud of was the fact that he's stayed alive for the last 5 years and resisted the temptation just to end his life. Because every day it's a struggle not to succumb to that temptation. So there's so many people who, and we lose so many people every year. Suicide rates. There's over 40,000 Americans who take their lives every year. Most of that is associated with depression or other mental illness. And so when other things fail, we know not doing anything is a risk. So I was able to get it approved based on that. And we started giving the treatments, and we saw really remarkable things that I didn't think I was going to see.
So like what? Talk to me about one of your kind of success stories.
Well, one of the success stories was early on was a person who had treatment-resistant depression and was actually had decided, and I learned this after the fact, after we had treated him and he had become he had become healthier. He had decided to end his life, and actually had picked a date to commit suicide. He had actually obtained a kit from a group in Scandinavia that helps people,
end their lives.
End their lives in a non-painful kind of a way. And he assembled this kit. He had it already, and he somehow heard about these research studies with ketamine, and he was a resident of Los Angeles, and he had looked up if anyone was providing it, and he found out that one of the only people providing it, lo and behold, was just down the road in San Diego. And he had emailed me, and the truth be known, I didn't respond because I was actually being inundated at the time with people emailing me. And he told me later that he said he was going to try one more time. And when I went back, I had chills finding his email. It said, this is all I can barely do is to email you. I hope you see this. Please consider me. Well, I had finally gotten through my inbox and contacted him. He came down. We assessed him. We felt he was a good candidate. He didn't reveal that he'd already set a date.
Okay.
We set the date for the infusion. We were giving it as an intravenous infusion, and he we thought he was having a bad reaction because we heard what seemed like sobbing, and we actually stopped the infusion, and I went to check on him, and indeed that's what it was. He was sobbing, and he said.
Let me just stop you there.
Yeah.
You actually stay with the patients for the first 30 minutes of their treatment.
Right. It's myself or somebody else.
So someone right. is there.
Right.
Yeah. Okay.
And he said that for the first time in his life, he understood what it's like to feel normal and to feel and to feel like a good person, because a lot of times. In depression, people have extremely negative self-derogatory thoughts, like they're worthless and they're just taking up space. And it turns out that he had a very, very difficult childhood, and he never received sort of some of the validation that we think about as a normal process of being loved and so forth. And it was the first time. And this was somebody in his 40s who felt that, and we were able to continue to treat him. He's well to this day. Wow. We keep in touch, and he's very successful. And to give you an example, because in case your listeners feel that people with depression are non-functional, or this was a person
like fit a stereotype.
Exactly.
Yeah.
This was a person who actually. Was his business was taking off, and he had sort of a dream sort of breakthrough in terms of a contract, and he told me that the clients were calling to kind of finalize the details, and he couldn't pick up the phone. He just couldn't do it, and he knew that he was letting his dreams slip through, but he just couldn't do it, and that just goes to show you that that a lot of these people are bright, they're creative, they have a lot to offer, but they're just so shut down. So those were the kinds of experience that made me realize that this was really something new. And what's interesting about ketamine is. It's a model, if you will, for a whole series of medications. Now, you think of ketamine. You mentioned it's a recreational drug, and indeed, it has been utilized by many people recreationally because it has mind-altering properties.
Okay.
The same mind-altering properties that can be therapeutic can also be used if you're seeking just a new experience or wanting to just recreationally change your state of mind. And so at the low doses, ketamine essentially is a psychedelic drug.
Okay.
And what's interesting about this is that because, in large part because of what we've learned about ketamine's effects at the doses that produce this psychedelic, you may be surprised to know that right now, and there are a number of drugs that you would never imagine would be brought into the realm of normative medicine, like MDMA, which is the active ingredient in ecstasy, psilocybin, which is the active psychedelic ingredient in mushrooms, and even LSD, are all under development under the auspices of the FDA for things like depression, PTSD, and other things. Now that may sound really far-fetched, but that's how revolutionary these drugs are, and to the point where the FDA is recognizing under proper circumstances and used medicinally, these drugs that we associate as sort of as powerful mind-altering drugs that are used recreationally that are banned can really have incredibly therapeutic effects.
So we touched upon this earlier, but earlier this year the FDA did approve a type of ketamine.
Right.
Does that mean that we can buy it now? I mean, what's the situation with it?
So yes, there's a pharmaceutical company called Janssen did develop a nasal, nasally administered version of a slightly altered chemical to ketamine. It's called S-ketamine. That drug is not widely available for a lot of technical reasons. Insurance, although it's FDA approved, insurance companies are just coming on board to get that. It also requires almost as much monitoring as the intravenous or the intramuscular versions that we give, and there's just I would say systems blocks right now in terms of getting doctors reimbursed for that monitoring. So it's really not, as far as I know, and we did a little a survey, calling different providers that are listed like we are as certified providers of this. We didn't find a single one of them that was providing it currently, unless the patients pay out of pocket. So
talking about money, how much does your treatment cost, and can you get insurance to cover it?
So the TMS is quite commonly covered by insurance.
Okay.
Most insurances will cover it if a patient has clinical depression and has tried antidepressants.
Okay.
The ketamine, the actual ketamine, not this new version, is not covered because it has not gone through the approval process by the FDA, and the reason it hasn't gone through the FDA approval is because that requires many millions of dollars to do, and because the drug is so old, been around for 50 years, it's off patent, and that means that there's no major monetary incentive for a drug company, for example, to spend the hundreds of millions of dollars to do the FDA approval process when it would immediately be open to generic competitors.
Where do you see this market going? Do you see that ketamine may become like cannabis is becoming now, more widely available, and obviously, the stigma that was attached to cannabis isn't so much anymore? I mean, where do you see ketamine going?
Well, in the dozen or so years that I've been using ketamine to treat people with psychiatric conditions, I've seen a major transformation. As I mentioned early on, it was very uncomfortable because a lot of people felt it was very inappropriate to be giving this drug that is a psychedelic drug, club drug, and and hasn't been tested, with repeated, because you need to kind of continually give this to patients on, repeatedly to maintain the effect. But now there's been so many studies that have come out that have shown its safety and efficacy that when I started, as I mentioned, we were the first program at UCSD to provide this for clinical use outside of research. And now there are hundreds of clinics around the country that are providing ketamine. Some of them more professionally than others, but it just goes to show how much acceptance this has garnered, and even the American Psychiatric Association now has come out with guidelines, whereas early on they wouldn't consider doing guidelines because their position was you just shouldn't be doing it. It's only for research. Now they actually have guidelines of how it should be appropriately administered and so forth, and now we have an FDA approved version of it. So it's really coming along. If the biggest barrier, honestly, Claire, right now is the fact that it's not FDA approved, and that's a technical issue in terms of how our system works and how drugs get developed and how things get FDA approved. There just isn't a good financial rationale for anyone to spend the many millions of dollars to get it FDA approved, and so it doesn't go FDA approved, and therefore it doesn't get covered by insurance. Now that's our biggest barrier, and if insurance were to cover it, we'd be able to. The impact would be so much larger.
But I guess if it's not FDA approved, that in itself could be off-putting to someone, because the FDA is kind of, quality assurance that, you're getting a safe product, it's being tested. So, I guess that would be a possible deterrent to someone seeking treatment if they know it's not covered by insurance and it's not FDA approved. What would you say to someone who's really struggling right now? They may not want to get out of bed in the morning. They may be exhibiting all those symptoms we chatted about right at the beginning of our conversation. What do they do?
Well, they should understand that there are more than ever effective treatments for depression. If they haven't engaged a mental health professional to help them with their depression, obviously that's the first step. Is to see a psychiatrist or a therapist to start getting treatment. If they've already tried that and the antidepressants have not worked for them, the talk therapy has not worked for them, they should know that thankfully now we have really good alternatives like TMS and ketamine that can work in patients when the other treatments have failed. And they should also know that we are finally in a place in the field of psychiatry where we are seeing a pipeline of really new and different treatments coming down the road, whereas for many years we were kind of spinning our wheels with the same old versions of treatments that we've had for decades. So finally, it seems like we're getting a little bit unstuck, and we're making progress, and it's a really exciting time. So even if they're not finding anything that is doing it right now, there's reason to hope. And what gets me up in the morning and getting going into work is the amazing gratification we get from so many people who will say, 20 years I've tried everything, and it seems like I'm just starting to live now. And we get so many cases like that. Of course, we don't get it doesn't work all the time, and that's our goal, is to have enough treatments and to find ways to use the ones that we have in a way that will be able to to get everybody who walks through the door to that place. But right now, just the fact that we see so many people reclaiming their lives. And when you treat a person, it's often not just the one person's life you change, but it's family members. And I've had people write me letters and emails saying, thank you for giving me my mother back and my spouse back, or my child back, and so forth.
Yeah, because this isn't just affecting the individual. I mean, it's far-reaching. It's going to impact the family. I mean, how can family members help in this situation? What do they do? Well,
I think the first thing is getting educated. The thing about depression and psychiatric illnesses, it's much harder for people who aren't experiencing them to understand what's going on. It's much easier for us to understand a fractured limb, even cancer. We get that there's something in the body that's out of whack and is causing illness and is life-threatening. But it's very hard to understand why somebody who's intelligent and ambitious just can't get out of bed, just can't get anything done, just doesn't want to pick up the phone, regrets every morning when they wake up and they realize that they're still alive. It just seems so alien to people, because we have this sense that we're in control of our feelings, but the truth is that's true to an extent. But when the machinery that is responsible for those feelings malfunctions, it's really not in our control. And I've had patients say to me, I feel horrible on top of the depression because I have a wonderful family, and I have and have no financial worries, and I've had a wonderful career, and I should really be enjoying life, and yet every day when I literally can hear a patient saying these words to me every day. Despite all that, every day when I open my eyes and I realize I'm still in this world, I'm disappointed because I don't want to be here anymore. And I feel terribly guilty because I know there are people in really bad circumstances, and I feel terrible that I feel this way about my very good circumstances. And yet
Anthony Bourdain, Kate Spade,
exactly,
high-profile celebrities who had everything to live for.
That's a
and
great
just couldn't.
Right. Despite it all, it didn't satisfy, their soul's, need for happiness and contentment. We may have looked at them with envy, and they hated being in their skin.
How does this work affect you? Because it's got to impact you to an extent. You're sometimes dealing with people, David, who are literally on the edge. They're telling you that they have nothing to live for. So how does that affect you?
Well, I've sadly lost patients as well, because we don't always win the battle. But
and how does that impact you?
Well, I'll tell you. Overall, despite what you might think, it actually personally is improves my quality of life, because it makes me more grateful.
What, when you lose a patient?
No.
You need to clarify this here.
Sorry. Losing a patient is devastating. Yeah. But it makes me more grateful in my own life.
Okay.
It really puts a perspective on things, and it makes me feel that but for the grace of God go I. And if I can be on this side of the equation and offering help to others, that is a privilege. Because any of us could very easily be on the other side of this or any other medical condition. So I really view what I do and medicine in general is really this almost holy, noble endeavor, where those of us as medical providers are given these amazing opportunities and tools to help other people, and to be in a position of giving, because as I said, we could easily be in the other position. So it just, when I'm feeling a little sorry for myself, I just think about the struggles my patients go through every day just to get through a day. Just to get through a day and stay alive and not succumb to the temptation of exiting, and it just puts everything in perspective.
Wow. And we can't not have a chat about Kadima without mentioning the true star of the show, Copper the dog.
Copper the dog.
For anyone that doesn't know about Copper or who would like to, have a little sneak peek, Copper, there was a lovely, cute video on your website of Copper in action.
Yes.
But tell us, what does she do?
And with produced and narrated by a very talented group of people.
Yeah, I mean, the listeners can decide that for themselves. But the dog's cute.
The dog's cute.
Tell us what she does.
Copper is our therapy dog. She's a sweet 1-year-old now, mixed beagle, who comes into the office and without really needing to train her much, gravitates to our patients, loves them, and produces an effect that is on par with our high-tech TMS or ketamine.
Crazy.
Because a lot of our patients are anxious about their treatments, especially at the beginning, before before we started. And Copper will just open that door and call her in, and she'll look around and see that new person, jump on them, lick them, and we can just see the anxiety just melt away. And I was, as I was telling you before, it's got to the point now where people are coming in and asking for Copper or trying to schedule their treatments at a time when Copper will definitely be in, because
you might need to clone her.
We might we might need to do that, absolutely. So it's really it goes to show you the amazing therapeutic property of not just medicines, but there are natural medicines that affect our brain and just tap into those circuits of happiness and pleasure that are so powerful. So we consider her as part of our armamentarium, just like any of our treatments.
Well, Dr. David Feifel, it's been an absolute pleasure chatting with you. Thank you
Likewise.
so much for coming in, and all the best.
That's my pleasure. Thank you.